everyone. I just wanted to talk to you a little bit about some reimbursement basics, just to give you a kind of a base to work from moving forward. It'll be really helpful for when we get into some of the more detailed conversations moving forward in our program. So we're going to start out with a brief discussion of medical coding. I'm sure some of you probably have some basics about medical coding, some basic knowledge maybe from your work or just even from being in the healthcare environment. But I'm going to talk a little bit about medical coding because it is really the root of most of our reimbursement systems. So we're going to talk a little bit about medical coding and how that works, and then we'll talk about our reimbursement systems. We're really going to focus on Medicare because Medicare is really where a lot of our reimbursement systems come from. We're not going to focus on kind of some of the advanced reimbursement systems. I'm going to stay with the basics for today. When we move into courses in the second year of your program, so when we move into our population health courses, and actually some more discussions later in this course, we will talk about some of the more managed type programs, or as we get into more discussions of things like patient-centered medical homes and coordinated care. We will talk about some of the more advanced reimbursement systems that are kind of more innovative. But for now, I want to give you the basics of reimbursement because without those basics, it's hard to understand those more advanced systems. We are going to focus on the hospital and the physician practice because those are obviously our building blocks of our other settings. I will talk briefly at the end about kind of some other settings, but we are going to focus on the hospital and the physician practice. So let's start by talking a little bit about medical coding in the hospital. So in the hospital, there are mainly two sets of codes that we will be using on the inpatient side. So when I talk about medical coding hospital, I'm talking about inpatient. So think about when, if you were to go, say, to the emergency department and they would say, okay, we're going to admit you for an inpatient stay. You have a heart attack, you have a gallbladder attack, and you need surgery. That's going to be an inpatient stay. So if that is you, or hopefully it's not, but if it were to be you, you're going to be an inpatient in the hospital. And in those instances, you're going to have a certified inpatient coder. They may be somebody that's trained through a certificate program, but typically through an associate's degree program that is going to have a certification. And they're going to do what is called abstraction. So they're going to abstract your record. And they usually use a logic-based program, a computer program called an encoder. And from that, from your record, they're going to pull out ICD-10-CM codes for diagnoses and ICD-10 PCS codes for procedures. So those codes are all very, very important to our reimbursement system. Without those codes, they will not be able to submit your claim, and no reimbursement will be able to come. So coders are very, very important to our reimbursement system. Without coders, hospitals would not get reimbursed. And coders need to be accurate, and they need to do quality work. Their coders are vitally important to the compliance of an organization. On the physician side, it's a different picture. So not that coders don't have to be compliant, they have to be equally as compliant, but it's a different coding situation. So coders on the outpatient side or the physician practice side have to code a little differently. So for diagnoses, it's the same picture, ICD-10-CM codes, but procedures are coded using CPT-4 codes, which is a different type of code, and also HCPCS Level 2, HCPCS, which we pronounce as HCPCS Level 2 codes. Now, hospital outpatients are coded using these same codes. So if you were to have a radiology service or a lab service or an outpatient surgical procedure in the hospital, these are coded using the same codes in the hospital setting. and those services would be coded in that way. However, coders don't usually code those in the hospital outpatient setting. Those codes come from what's called the charge master. So it's all kind of complex and confusing unless you work in that revenue cycle reimbursement setting. And if you ever want any more information about that, feel free to contact us. We'd be happy to talk with you further about it. But from the 40,000 foot view, know that these are the codes used for the outpatient setting. And so in the physician practice, they are assigned either by a coder, or sometimes they're even assigned by the physician themselves or the provider. So sometimes the provider will choose the code that's being performed. It might be an office visit or a surgery, and then that's assigned. However, what's becoming increasingly popular in the outpatient environment is a service, a product called computer-assisted coding, which is where a computer product, software product, actually reads the electronic medical record, makes a determination on the code based on some natural language processing, and then the codes are actually validated by a coder. So from a compliance perspective, we would never allow a computer to just choose the code and submit the claim, because that would be way too risky from a fraud and abuse perspective. But it does cut down the cost on coders by having, because to be honest, certified professional coders are expensive. So it does cut down the cost on coders if we have computer-assisted coding products code the claims and coders validate the claims. There's a lot fewer coders required in those instances. So let's talk about the reimbursement side. This is more of what we need to know. So from a reimbursement perspective, a lot of times we talk about charges. So when you go to the hospital and you're in an inpatient setting, remember that heart attack or that gallbladder that I talked about. So if you're admitted to the inpatient setting, you may see a bill from that hospital say, and it may say that you had $30,000 in charges, let's say, for that inpatient heart attack. You're not going to pay that $30,000, nor is your insurance company, because that's not the way claims are reimbursed typically. Let's say you're a Medicare-aged patient. So Medicare pays on a system that's called the Inpatient Prospective Payment System, IPPS, and they pay on a system that's called MSDRGs. So what the MSDRGs do is they use ICD-10-CM and ICD-10-PCS codes. So those are our diagnoses and our procedure codes. And in some cases they use demographic information, they use some other information about people that are admitted, but typically it's just the diagnosis and the procedure codes. And then they group those admissions into different groups. Could be one of 700 different groups. And these groups are groups that they are about consumption of resources and length of stay. So imagine all of the different types of patients that could be in a hospital. There's a lot more than 700 different clinical practice patterns or disease pathologies that could be in a hospital. So that's a small number of options. So for every one of those different DRGs, MSDRGs, there is a payment for a certain hospital. So if I am a patient that comes in with a heart attack, and I meet a certain criteria, a certain set of diagnoses and procedure codes, and I'm in for 3 days, and the person that's in the bed next to me meets the same set of criteria with diagnoses and procedure codes, and they're in for 6 days, but we meet all the same diagnoses and procedure codes, and our charges could be wildly different. I could have $30,000 in charges. They could have $50,000 in charges. If we're both Medicare patients, the hospital is going to get paid the same for both of our services, because that's the way that system is created. And I'll show you an example here on the next page. So charges don't really mean anything when it comes to payment under the DRG system. So think about it as it's payment based on the diagnosis and procedure code, not based on the charges that go into the system. There are some instances where charges do come into play. That's what are called outliers, and that's when there's a radically expensive service on the claim, like a very, very expensive device, maybe a $100,000 device or something of that nature. But that is very, very rare. So rarely, and if you were a facility that had a large number of those, you would be a red flag type facility where they would be auditing your claims. So it should be very rare that you would have those types of things. So this system has been in place since 1983. Back before that, hospitals were paid based on cost. So it was not efficient. If you were not efficient, you got paid more. So it wasn't in a hospital's best interest to be efficient. So Medicare said, oh, wait a second, we're paying hospitals more when it costs them more to provide services, so we're losing a lot of money here. So we want to fix this system so it behooves the hospital to be more efficient. If they get a person out of the hospital quicker, they are more likely to save money and therefore make money on this case. So every October we get new DRGs, new base rates, new everything. So let me just show you a little example here. This is an example of a DRG. This example is DRG 470 for knee and hip replacements. So I have 3 different hospitals here. The national DRG rate for this is from 2013, this example. The national DRG rate for the knee and hip replacement is $5,631. You can see that on this top line. So this is 3 different hospitals. So this is the base rate, the national DRG rate, not specifically for the knee and hip replacement, but just the base rate overall. And then every DRG has what's called a weight. So it's based on the resources that are used for that particular service. In this case, the service is a knee and hip replacement. So our weight is 2.0866. So we're going to multiply our base rate by that weight, and we're going to come out with $11,750 for our particular example here. Now, every facility is going to have different adjusters. We're going to have adjusters for what they call a wage index, which is an adjustment based on labor in that area. We're going to have adjustments for medical education. We might have adjustments for disproportionate share, which is like a bad debt and charity care adjustment, etc. So every hospital is going to have different adjustments. In this case, I have 3 different situations of adjustments for every hospital. So this is 3 different hospitals, and they're going to get 3 slightly different payments for the same service based on the adjusters. So in all of our different situations here, we've got a typo in this last option. I apologize for that. So we have slightly different situations here, but but all in all, we're getting around the same payment for our services. In this case, this facility has some indirect medical education. This facility likely has maybe residents working in their facility. This one maybe doesn't have as many, or doesn't have, maybe they have allied health workers in their facility doing education, etc. So it all depends on what's going on in your facility, but in this case, maybe the charges for Hospital A were $30,000. The charges for Hospital B could have been $10,000. this case, we're losing money because in hospital A we're only getting paid $17,993. For hospital B, we're getting paid $13,000. So we could be winning. We could be winning money. We could be getting additional monies, making money on that case. So it all depends on the case and how well we do there. But the point is, we're not going to necessarily get paid based on charges. Definitely not for the Medicare program. There could be commercial payers where we could get paid a percent of charges based on our contracts, but for the Medicare program and Medicaid programs, not likely to get paid percent of charges in any instance. On the outpatient side in the hospital setting, for the outpatient, the majority of our outpatient services, we get paid under a program that's called the Outpatient Prospective Payment System as well. And it's not exactly like the DRGs, but it is a similar program in that we don't get paid based on charges. We get paid a fee based on a mechanism where they look at what we've done, and some payments are packaged into other payments, and it's a similar mechanism that they do look at all of the services that were rendered and pay us an overall payment based on all the services that were rendered that day. So again, it's not paid based on the charges that were charged on that day and a percentage of those charges. It's based on an overall look at what was done that day, and it's a prospective payment system. So prospective payment is a risk-based system in that they look at all the services done that day, and it's the APCs are a packaging-based system in that they'll package certain items into other items and pay us kind of a packaged price in that case. Laboratories are based on a laboratory fee schedule, so we are paid based on a laboratory fee schedule for Medicare. And if there are freestanding physician practices, there's a difference between hospital-based physician practices and freestanding physician practices. They could both be owned by the hospital, but there is a big differentiation based on corporate structure. Hospital-based physician practices are paid under the outpatient prospective payment system for the hospital portions of it. The physician practice, the physician work component is paid under the physician fee schedule, which we'll talk about in a second. But if it is a freestanding physician practice, that is paid completely under the physician fee schedule, which we'll talk about right now. So let's talk about that physician side. So for the physician practice side, for those of you that are interested in the physician, I know many of you are interested in moving into physician practice management or into the physician side of the world. Under the Medicare program, we are paid, if you're a traditional fee-for-service physician practice for those sides of the business, we're paid under what's called the RBRVS, or Resource-Based Relative Value Scale. And this is a fee schedule. It's based on that CPT code that's assigned, which I talked about back at the beginning. And also you have to have established medical necessity. So you can't just have a surgery for no reason. There has to be established medical necessity. So the physician has to have made a diagnosis, and there has to be medical necessity established for that service. And the RBRVS is made up of 3 parts. So what this is an actual numeric scale, just like that DRG weight that we just looked at. It's a numeric scale, and it has 3 pieces. The first piece is the physician work component. So it's based on that the actual work of the physician, their time, their effort, their skills, and this is 55% of that number. So you might look at, say, an office visit, and then compare that to to a neurosurgical procedure, and that the physician work component is going to, those numbers are going to be much higher from physician work for that neurosurgical procedure than they would be for an office visit, just because the time taken for that neurosurgical procedure is going to be much higher. The mental effort, the skill is going to be much higher for that second procedure than it would be for that office visit. Practice expense, that's what it sounds like. So staff costs, utilities, rent, all of that stuff. That's 42% of that overall cost, or that RBRVS piece. And then the last piece is only 3%, small piece. Professional liability or malpractice is that last piece. So those are the three elements that go into that overall number, that RBRVS number. And then that's actually multiplied by a conversion factor to come up with a fee schedule to pay for the physician fees, or I shouldn't just say physician, it's provider. So it could be nurse practitioners, it could be other non-physician practitioners like physician assistants, but all sorts of different providers in the physician practice world that are reimbursed under this RBRVS or Medicare fee schedule. So that is how physicians are reimbursed generally under Medicare. But to be honest, the RBRVS fee schedule is widely used throughout other non-Medicare reimbursement situations. Many other payers use the RBRVS fee schedule, or often referred to as RVUs. Actually, many organizations use RVUs to pay their physicians. They'll use those those numbers, those three different pieces, the numbers that come from them, to actually calculate their salaries. So based on how much work they do throughout the day. So RBRVS is very important from the physician side or the provider side of our business. From the hospital side on non-Medicare, there are many different reimbursement scenarios. There are other types of DRG options, APR DRGs, that's another type of DRG reimbursement scenario. A lot of Medicaid payers use that particular type. It's just a slightly more refined type of DRG than the MSDRGs. There are other, like I'd said, sometimes some payers will actually use a percent of charges reimbursement scenario for inpatient stays, for outpatient hospital charges. So it's all based on your contract. What's interesting about reimbursement is that outside of governmental payers, it's all based on what you negotiate as a provider with your payers. So payers and providers need to negotiate carefully and create a good scenario that works best for both payer and provider. Other settings like long-term care, vendors like DME, they're all paid in various different ways. There are actually prospective payment systems for long-term care, psychiatric care, in the inpatient side, for Medicare as well. So they're really moving toward that prospective risk-based system for all settings for Medicare. Really important to be aware that that's the kind of the way they're moving. And then on the practice side of things, they really kind of stay in that fee schedule setting. Like I said, for laboratories, fee schedule. Most of the outpatient side of things are more of a fee schedule like option. Even that APC, of the outpatient prospective payment, looks a little more like a fee schedule than it does like the laboratory. It's a package-based system, but it's kind of built on a fee schedule. So it's a little less risky than, say, the DRG scenario is. So that takes us to the end of our presentation on reimbursement. If you have questions, please, please let your instructor know, and make sure that you review the chapter on reimbursement options in the textbook as well. Thanks so much.